And the panel is Rapid Build and Scaling of Mental Health Rehabilitation Center. So I would like to invite Doctors ILAN HARPAZ-ROTEM from PTSD Care, Yale University, Dr. SONYA Norman from Moral Injury Care, University of California, San Diego, Dr. Noah Phillip from Novel Rapid Therapies Accelerated TMS, Brown University, Dr. BEATRICE, PATSALIDES, HOFMANN, Primo Levi, and Dr. OLEH BEREZYUK from Mental Health Unbroken Rehabilitation Center in Lviv.
That's dangerous.
Yeah.
Let me see. Just a second.
Do we need to join this?
I need to join the Zoom. Who did I man? I send it to. Oh, it's rejected. Okay, so I'll need to join the Zoom. Huh?
Do you want to introduce us?
Recording in progress.
Oh, Sonia is here. Yeah, she's with us. She's up there.
She has been here.
Cool. Thanks. I can share. Yeah.
She's in Pacific time. So what time is it here? Oh, it's not too bad. It's not too bad. Oh, I had a conference.
Can you hear me? Thank you, and it's a pleasure to be here. And with there is echo. Oh, let me just close the mic, probably. No,
You're muted. You should have
Yeah.
echo. Is there an echo?
Do you have an echo? I know. Let me just. Yeah, good. Yeah, sorry about the delay and the technology, but it's a pleasure to be here with Sonia and Noah and Beatrice and Ole. We have done work in over the past 3 years in Ukraine, trying to build kind of a program that will address the needs of mental health care. And I will go over this idea because it's kind of building something from the ground up without any really prior knowledge of what is to deal with such a horrifying and painful trauma, war consequences. So again, this work would not be possible with the help, of course, with the Doctor United from Ukraine group at Yale School of Medicine and Yale Macmillan Center for International Affairs that really supported our efforts. And I want to acknowledge Professor Marta Kuzma from the Yale School of Art, actually, because when we started, I think Ole and her connected, and she brought us together. She's very actively involved and passionate about helping Ukraine, and she made this initial connection. Our work was really recognized by the mayor of Lviv, and I think the honor to meet also the Ministry of Veterans Affairs that Olo introduces, and this is a really meaningful work for me, and hopefully we can able to help. So when we started this project, I think when Ola and I connected first, it was extremely important to address immediate needs and gaps in care. So I think the first step of establishing mental health care program is really mapping the needs and knowledge and what is needed. And we had multiple conversations on how to design the training program that will address the mental health needs in Ukraine, in Lviv Medical Center. At the time, I think Unbroken was not yet built, and the first two training sessions was actually in Warsaw. But I think what we worked is the operationalizing what the information that Ole communicated to me, and really to build the training program and how to best implement it based on the situation. It was difficult to bring male therapists out of Ukraine in the beginning because they were not allowed to cross the border. So that we did as much effort as we could that we be on the ground as soon as possible in Lviv, so a lot of more diverse population can attend this this training. I think overall the YALE team, the treatment and research laboratory that I run at YALE, had done 7 trips, and we're about to be there again in a week to do our 8th training session. So when you do training in mental health, what are the immediate needs that we identified? So over the conversation and initial conversation, we realized that the background and the way that people worked and treated trauma in Ukraine was driven mainly by psychoanalytic, dynamic psychotherapy models. And that's something that we registered because we thought about how to address this gap before implementing evidence-based psychotherapy. And one gap that we really identified, again, when you do thinking about cases, when you're coming from a different theoretical background, you think about it not straight in the DSM diagnosis. So work really get training in basic diagnosis and comorbid condition for PTSD. And PTSD is very complex because it's heterogeneous. It's a lot of overlap symptoms. To do differential diagnosis is extremely important. But we don't want to erode this thinking and what people have already gained for many, many years as a base knowledge. You don't want to go against it. You want to work with them to buy-in. In order that you think in terms of what you learn and trained in the US and integrate the thinking to their thinking in order to have a large buy-in. And I think this openness and willingness to learn by Ukrainian doctors and therapists was amazing. It was one of the most rewarding in the terms that they are really eager to learn, and they are implementing and integrating in this kind of, I never was approached by this level of enthusiastic to assimilate and move forward. But I think part of this enthusiasm coming that when you design a program, you need to design it clearly to the way that people were integrated and educated and thinking about medical care. And what at the beginning was very important for us to do training in acute stress disorder, differentiate what is called PTSD is what it's failure to recover. So there is a symptoms that comes quickly after exposure to horrifying, like the war and the bombing, and not misdiagnose those cases of PTSD and try to differentiate what is acute stress disorder and what is then developed to become a PTSD and how to address it. That was like in immediate needs that we addressed it. One of the other major things that were addressed, and Shelly Amman did a great job as a veteran herself, is understanding military culture. And a lot of those soldiers, when you are sitting with a young female psychiatrist, 24 years old, not necessarily want to open up. So teaching those clinicians about the military culture and how to work with military personnel was extremely important. So we're building those training programs. Then there is the stigma issue and overcoming stigma and other things, you know, you saw, I didn't put any picture, it's kind of boring versus operation, but those invisible wounds. You have some amputees, but there is a lot of people without physical injury that also carry tremendous amount of trauma, guilt, and shame of things that happened throughout that process. And that was extremely important for us in the training. Was, okay, now we want to implement evidence-based psychotherapy. DOD, VA, and APA some guidelines, but we thought, okay, what kind of psychotherapy will work with what the people on the ground already knows, what we can integrate? Should we go and teach them cognitive processing therapy? It's, you know, where the very complex approach and training, or we choose the most parsimonious treatment modality now available in the market that seems to work very well and can be done very successfully also in what is called intense treatment. Within 2 weeks you can finish that. So we decided to go with prolonged exposure psychotherapy, and this model works so well. The people were, again, the buy-in, the ability to take psychodynamic thinking, where they came from, what the knowledge base, that was tremendous. This is very important knowledge that they had, and how we bring evidence-based psychotherapy to that group. So we decided to go with one model of prolonged exposure, and of course, the word of psychopharmacology, how to manage medication-wise. PTSD was kind of really new. I think the approach was really doing mostly psychotherapy, but how we can enhance psychotherapy with the combination of psychopharmacology. So that was the initial model, the few training that we conducted. But then, oops, I'm not seeing anything here. Okay. I'm sorry. So that's hard. Okay. I don't have my multifocal. So last quickly, then it's evolving. We evolve over time when we really, that we need to address new things as we learn and move through a very dynamic system. We move to addressing special mental health needs of prisoners of wars. Now, this is something that was not really present at the beginning, but then soldiers started to get back from captivity with a tremendous amount of issues. We have also had to address this the vicarious trauma and burnout. People, like so many patients, horrible, horrible story. How we make sure that our medical staff and psychotherapists stay healthy, develop some training to address this burnout in this population. Understanding the neurobiology of PTSD was extremely important, because when you do medication management, psychotherapy, you can move toward what is called precision medicine. You want to address the specific symptoms of PTSD because you have many systems working. You have anhedonia, you have re-experiencing, you have vigilance, you have cognitive distortion. Each one might require different medication or different psychotherapy approach. So therefore, like trying to teach them a little bit precision medicine to kind of fine-tune what we already trained them in the beginning. Then, of course, we had this pleasure to introduce new pioneer work by Dr. Noah Phillip about TMS and also biofeedback. Again, we are building block from the basis, like a small pyramid that we slowly working with the centers. We have the pleasure to have SONYA Norman in a second talking about moral injury that really develop a whole new set of treatment approach to address this painful moral conflict about what you observe in war, what you experience, and how to live with your moral compass. Suicide. Suddenly we get a call. We are raising suicide. Then we package this suicide prevention program into our new training program. And I think the next step we'll do like training of peer support, because in the US Veteran Affairs, we have a lot of veterans that runs group, not psychotherapy group, but support group that really enhance the capacity of those people to feel connected to each other. So we always constantly surveillancing and moving quickly to see what are the needs and reshaping the program. It's not a static program, it's ongoing and revolving all the time. The big miss, and what we need a lot of support also from the community here, is to do research. We have the tremendous amount of work done in Ukraine. It's not well documented in all fields. And you can see in the war between Hamas and Israel, there are already like paper in JAMA Psychiatry, there are all paper in Lancet. You know, it's people like recording, but the amount of injury or prison of captivity, and I had like family that were in hostage in Hamas. I feel strongly, but thousands of people in Ukraine were released, and we don't have documentation well documenting how they are being treated, how they being. So we are developing now kind of a model to just expand research. But for you as Ukrainian, and you're doing amazing work. We all been there so many times, and you saw the work. We need to support you in kind of starting the research infrastructure so you can communicate your accomplishment and the pioneer work that you're doing right now in psychiatry and mental health. So that was my spiel, and I want to give the stage to Sonia Norman to talk about the program of moral injury. Sonia, it's yours.
Great. Hi. I'm sorry I can't be there in person today, but I'm very happy to be here with you all. I'm waiting for the slides to be shared. That's Dr. Phillips' slides. Do you have my slides, or I can share them?
Can you share your screen, Sonia?
Yeah, let me try to do that.
We can see them. We have them up.
No,
Can you
that's
see them?
not.
Yes, yes.
Can you see my slides now?
Yes. Yeah.
You can?
We can.
Okay.
Yes, you're good to
I'm
go.
gonna start then. So I was invited to do a training with the Unbroken faculty and students and staff and other invited members of the mental health community in Ukraine on moral injury. And just to define what that is, a lot of times traumatic events are more fear-based. Someone is the victim of an assault and they walk away fearful, and that is the stem of their PTSD. But also very commonly, more traumas involve potentially morally injurious events, where someone does something or fails to do something or witnesses something that transgresses very deeply held values. And this is particularly common in war, when people are acting outside of their values that they live by in civilian life. So most anyone who experiences such an event would feel moral distress, some upset, some moral pain, but many recover or make some sense of it or find a way to move on. But some go on to have lasting psychological, biological, spiritual, cognitive, behavioral, or social impacts of these moral injuries that are really core symptoms are guilt and shame, but also a lot of functional impairment, a lot of pain. This slide goes through some common examples that happen in wartime, and there's just endless kinds of situations. But to bring this to life, I'll share two examples that I heard in Ukraine. So one was on a trip where we were working with the Ministry of Health in Uzhhorod, and we're training peers. And after presenting on this, a peer came up to me during the break and told me when he had been in combat, he was a commander who was in charge of deciding who was sent out on missions on which day. And there were days where no matter, he knew that whoever he sent would die. 100% he knew they would die. And yet he still had to make the decision of his men, his troops, who to send. And now he had to live with that. Another example was when we were at Unbroken, we did consultation with the clinical team there. And one of the psychiatrists presented a case of a recently released man who had been a prisoner of war for 5 years. He had been through so many tortures and unimaginable trauma, but one of the things that still stayed with him was the people who he couldn't help, that he couldn't save, that he felt responsible for some of the deaths and some of the things that occurred. So those are examples of morally injurious traumas, and the lasting effects can be many things. So I was able to get a grant to help support some of this work through the International Society of Traumatic Stress. And we were able to professionally translate a validated measure of moral injury that first asks if people have experienced a morally injurious event, and then asks them about common symptoms of moral injury, such as I don't deserve to be happy, my life has less purpose, I punish myself, I'm powerless, I should not be forgiven, I do not take good care of myself. So we were able to translate this and implement it in Ukraine, and share it with Unbroken and others there. And I'm happy to share it with any of you. You can also download it either from the National Center for PTSD website or the International Society of Traumatic Stress website if you search MIDS, Moral Injury and Distress Scale. We also did work with the scale that identified a score of 27 or higher as clinically meaningful, distressing, impairing moral injury. And we recently did a study where we looked at moral injury and suicide risk and found that those who met that cutoff of over 27 had a 3 times higher rate of current suicidal ideation and a 6 times higher rate of lifetime suicide attempts. So very important to assess moral injury. The other thing I was able to do through this grant from the International Society of Traumatic Stress was do a translate and do a training on our intervention for moral injury with the team at Unbroken and all of the people who attended. So it was a all-day training that we had translated in the slide deck and also the manual and the workbook for our intervention. And just very briefly, this is just a 6-session intervention that we suppose people do in the context of a broader treatment, where we really tackle kind of the most impairing parts of moral injury. So normally this is a longer training, but to give you kind of a 2-minute overview, we help people understand moral injury and how traumas can affect someone deeply in terms of violating their values and the pain that that can create. We learn about their situation, and we really identify what is it that they've been feeling guilt and shame about since the traumatic event? What is it that's causing their impairment, their sense that they don't deserve to be happy, their self-destructiveness, their deep pain? And once we do, we go through what it was they're really telling themselves. I shouldn't have, sent this person to battle that day, or I should have been able to stop this other person being beaten in the Russian, prisoner of war camp. And we go through some interventions to help them kind of get a broader perspective, because really we know that people with this kind of guilt and pain really focus on their own role. So we go through and we help them kind of just zoom out and think about what did they really know at the time? What kind of power and control did they have at the time? They've kind of been telling themselves there was a way to make things better, but often in trauma, there isn't. No matter what happens, there's going to be a bad outcome. So we help them consider what options were truly available at the time and what would have happened with those other options. And most often they realize, no, I couldn't have saved the day. And yes, what I did kind of made some sense in that context. We help them think about all of the kinds of things that contributed to the outcome of that event. So they had their role in it, of course, but there were also all these other contexts like the war and other things. So we help them consider all of those. This often helps people kind of more right-size their responsibility in what happened. But what we found is that suffering through guilt and shame is a very important way to express values. And so if we ask people, well, after we did this, what would it mean to go forward feeling less pain, less guilt and shame? They say, oh, no, then I would really be a monster, or then what would stop me from doing other bad things, or how would I honor the memory of the people whose lives were lost? So we realized that to truly help people find a path forward, we also need to help them find other ways to express those important values other than through suffering and through this moral pain and the self-destructive behaviors that keep them from finding a more meaningful path forward. So we say, wow, do you suffer when your values were violated? We can't undo the past, but let's look forward and let's see what are the values that are meaningful and important to you, that bring you a sense of purpose and maybe even down the road a sense of joy. And let's build those more into your life. And that's the last part of the conversation where we work with them very closely to kind of develop a path to very practically live more consistently with important values, so that we replace the way they express values with activities that are meaningful and purposeful and joyful instead of the ways they have suffered. In our first completed trial with this intervention, we found reductions in guilt over the 6 weeks that were maintained 3 and 6 months later. We found reductions in PTSD symptoms, depression symptoms, loss of diagnosis. We compared to a supportive therapy, and we really saw rates similar to our best PTSD treatments. And now we have 2 more trials in progress with many sites. This is just a photo from Ukraine, from the training, and screenshots of the measure and part of the intervention translated into Ukrainian. So I'm very grateful. This is really because Dr. OLEH BEREZYUK and ILAN and others saw the need for this. And I'm very grateful to have been able to do the work and to continue it. Thank you. And please feel free to get in touch with me. My email is here if you'd like any of these materials.
Thank you, Sonia.
Can we share it? Sonia, can you stop? Right. Can I share it now?
I stopped sharing.
Oh, sorry. No.
All right, I'll move back one. That's fine. Great. So thanks for the invitation to be here. My name is Noah Phillip. I'm from Brown University. I'm a psychiatrist there, and I'm also part of the VA Providence is my official affiliation. Thank you for the echo. So what I'm going to tell you about here is something that's going to be a little bit different. We're going to talk about using neuroscience to help people feel quite a bit better from a psychiatric perspective. My mission is to design, develop, and deploy new brain stimulation approaches for post-traumatic stress and all the things that come along with it, like depression and TBI and suicidal thoughts and behaviors. What we treat and what we are trying to do needs no introduction to this group. And I think what I do say is, as a physician who works in a Veterans Affairs system, is that we have a tremendous amount of experience dealing with not the same things, but similar things over many years. And I think there's a lot of ways that we all can learn from each other and advance this field together, really with the goal of getting people better and back to their lives. Most of the treatments that we use for post-traumatic stress in particular, we have 2 mainstays. And we have medications and we have psychotherapies. And they both work and they're both great. But they don't always meet our needs. Either there's challenges related to access, to use, or otherwise, and particularly in conflict and post-conflict environments. And so as an additional option, over the last, it's nearly 15 years or so, I've been working with a technology that's called transcranial magnetic stimulation. What this is we're going to use Faraday's law. So we're going to take a rapidly fluctuating magnetic field, and we're going to use that to induce electricity in a conductive media. But in this case, the conductive media is going to be the brain. It's described here, where we're essentially putting electricity through a series of copper wires. We create a magnetic field, and that magnetic field induces current in the conductor. Now, what do we do when we have technologies? We have to have different ways of using them. In clinic, we put our magnet over the part of the brain that controls the hand, and we find out how much energy it takes for illicit movement in the other side. That calibrates our device to each person and each person's brain for what they need. And once we've calibrated the system, we move our device over the part of the brain that is not working well enough when people have things like post-traumatic stress, depression, and what have you. And that's the dorsolateral prefrontal cortex, basically right under here. One of the neat things is that we've seen now over many years is that we can change how the brain works. This is a perfusion CT scan, and what it's showing you is the brain is changing after we stimulate someone. And not only are we changing the area that we're stimulating, when people get better with brain stimulation, there are many other parts of the brain that also change, and these are all involved in the illnesses that we want to treat, and they change for the better. So this is a treatment that's been around really since 2008 in the United States. Its typical use is once a day over 6 weeks. We're going to get back to that in a minute. We started at about 45 minutes per session. It's an outpatient procedure. It doesn't require anesthesia. This is a picture with myself and one of the prior VA secretaries when he came to see a little bit about what we were doing. And this is really we have a national program of transcranial magnetic stimulation across the Veterans Affairs system. It's headquartered in VA Palo Alto, and I work very closely with them to implement it. We have roughly 60 sites across the continental and greater United States at this point, and we've treated a better part of 4,000 people over the last decade since 2017 when we officially started the program. And a little screenshot from myself and one of my staff members in Providence. And what I want to show you is that this is an intervention that really reduces symptoms. So what you're looking at here on the top are depressive symptom reduction over time. That's the 9-item patient health questionnaire. The physicians in the room will know that one. And on the bottom is the PCL checklist for DSM-5, so gold standard self-report of PTSD symptoms. And the important thing here is that you can see that symptoms are going down over time. This is in the first 770 individuals that we had walk through the door, taking all comers no matter what. And these reductions in symptoms are meaningful. This is, as a non-clinician, you could see the difference in this person from the door. It's all statistically significant, and for those of you who like effect sizes, it's here too. But the other thing that you'll notice is that this takes 6 weeks, and this is not a good idea when we have to think about actual scaling. So what I've been developing over the last number of years is taking that 6 weeks worth of treatment and putting it into 5 days. This is the first 120 some odd people that we had come through our various clinics who got this protocol. People come in for 1 week. It's 5 times a day for 5 days. And I put that little dotted line there, and that's represent on this particular rating scale when we would no longer consider someone to have a threshold level of PTSD, and sort of more common ways of thinking about it, sort of like remission, whereas if the PTSD isn't nearly there. And so we can do that in 1 week, and this is really quite remarkable, and the effects persist over time. So what does this allow us to do? This allows us to start being creative, and you'll see where this is going to go from a Ukraine perspective momentarily. As one concrete example that we've done, we have an RV that's out in Montana. It drives around the state. It lives in a place for a week. It delivers its stimulation, and then it drives to somewhere else. And this allows us to bring these stimulators to the people who need it. So we have a scalable, effective device, and we're taking it to people as opposed to requiring people to come to us. So I was very, really incredibly humbled and flattered to be invited to come to Ukraine and teach this. And so the first was a little bit over a year ago, it was November, and I gave a series of lectures, and this really mimicked exactly the training that I do for VA physicians on a regular basis. So there's a series of lectures, and most importantly, really hands-on learning. So we had a whole bunch of different physicians and other providers, and I helped them learn how to best use the device that was there. I wasn't taking my American ideas of the different systems and fancy doodads that we have over there. Really spent the time making sure that they could use their equipment in the way that made the most sense for them. This was some of our first cohort. These are all people, I should add, who consented to have their picture in this presentation, allowed me to keep it and show it and share it, which was really fabulous. And one of the things that we did before we left the first time was, depending on their machine and their capability, we came up with a treatment algorithm that would work for them. So we had something that if someone had depression, we could treat that. If they had PTSD, they could treat that, traumatic brain injury, and what have you, so that they had something concrete, and we had their treatment protocols that they had before I left. We went back this last May. This is myself with a gentleman, his name is Martin Arns. He's at the Brain Clinics. It's a Netherlands-based transcranial magnetic simulation clinic. And I felt that in going back, particularly in light of the current situation in the world, that it was really important to connect Unbroken with some of our European colleagues, just given the state of affairs. And this is the good Dr. Arns demonstrating in front of a live clinical audience, or live studio audience, I should say, that finger twitch thing, and doing that on me in front of everyone else so that they could see what it was and to show that it was also no big deal. This was a group of the folks that we had that we trained the second time around. Dr. Arns brought a series of machines as well with him from the Netherlands, which was incredibly, incredibly generous and I hope helpful too for Unbroken. And so what I'll wrap up by simply saying is that this thing that we call transcranial magnetic simulation, it's a scalable, non-medication option for mental health rehabilitation. I think what we have here and what you're hearing about this morning is an incredibly innovative partnership with Unbroken, both from an education and dissemination perspective. And I would say, like you'll hear from others, we have a lot of ongoing needs in terms of making sure that we keep doing trainings and we figure out, we do some research, not just making sure what we are doing and what we're teaching works, but also allowing our colleagues in Ukraine to teach us. And I think there's an enormous amount of knowledge and wisdom that can be useful both in Ukraine and for many other parts of the world that is really being underutilized. And of course, as we have always, systems, machines, and things like that are expensive, and so we've been working to get more for them. There's a little piece here in JAMA Psychiatry that I wrote to try to raise awareness. That's a QR code with my cell phone and email address if I can be of help. And I really appreciate the invitation to speak.
Thank you.
I'll let you go for the next.
I think she has been.
We have your slides.
Hi. I'm going to speak to you about comprehensive treatment and care for survivors of captivity and torture in Ukraine. Healing Ukraine is an ambitious task. Approaching Unbroken Hospital in Lviv, in fact, 4 hospitals, military and civilian, adult and children's, one glimpses what healing might encompass. Near the entrance, one is drawn in by the softly splattering fountain amidst a huge water basin, projecting veils of shiny drops high into the sky. For one breath, time stands still. Drops today, not drones. Around the fountain, people of all ages gather leisurely, sipping coffee, smoking, talking with each other. Impossible to guess who is patient or doctor, civilian or soldier, except for those walking with new bionic limbs. We don't know what losses and assaults they each suffered, how they survived. Perhaps this indistinction between patients and caregivers reflects how Unbroken conceives of healing Ukrainians. Meet as humans first, then slip on doctor-patient coats. In ancient Rome, soldiers returning from battlefields were bathed by the Vestal Virgins to cleanse them of war's evils and moral injuries. Providing such liminal zones in space and in time remains crucial today, not only to treat survivors transitioning from war to civilian life, but also to heal the collective. Mourning the losses of each member, acknowledging the wounds suffered, and celebrating survival, then life as communal property, are central to Unbroken's comprehensive model, which includes group, family, and individual trauma-focused interventions for patients, and staff trauma prevention. What then should clinicians heed in particular when attempting to heal those who were captured and dehumanized? 3 aspects seem relevant to me. 1, torture, as Harvard scholar Elaine Scarry wrote, is the unmaking of a world. After captivity and torture, the world and oneself in that world will never be the same. Trauma creates temporalities before and after, with an unredeemable tear in between that words can only allude to, yet never fully name. Charlotte Delbault, a French resistance fighter and Auschwitz survivor, captured this chasm between the 2 worlds. I have returned from the dead, believing that gave me the right to speak to the others. And when I found myself facing them, I had nothing to say, because I had learned there that to the others you cannot speak. 2, that the unmaking of a world by torture and the experience of extreme pain includes an attack on the victim's capacity to communicate the trauma's very essence is well known. Alterations to lower level and primary sensory motor processes in traumatic memory function explain this from a neurobiological point of view. Physical pain, wrote Scarry, shatters language and causes a reversion to a state anterior to language. 3, regarding this shattering, Argentinian psychoanalyst Miguel Benasayac, who himself survived torture, distinguished 2 kinds of knowledge. 1, a knowledge on torture, which is academic knowledge, who tortures, how, and where, and which physical and psychological effects it produces. This knowledge on torture is reflected in Amnesty International catalogs and in our trauma symptom questionnaires. And then, said Benasayac, there is a second kind of knowledge, the knowledge of torture, which is the knowledge held by the victim of that chasm between the 2 worlds of the living and the dead, impossible to speak or to describe. Patients may at times half say it through metaphors, silence, or muteness. When returning from Russian captivity, Mykola, a Ukrainian soldier, weighed only half of his body weight. At Unbroken, he was treated for symptoms of starvation and severe PTSD. After captivity, Mykola told us, you come out with half of yourself, half of your identity only. Objectives of torture. Mykola's first art therapy drawing, divided by a thick vertical line, shows this split, this radical dissociation of the mind between the 2 worlds. On the left, childlike, vividly colored figures, the sun, a flying bird, a tree, a happy cow. On the right, stark red and black, a face engulfed in flames, at its center a mouth silently screaming. Torture does not kill. It forces victims to hover at the brink of death, helpless and speechless. Torture techniques leaving no visible scars, such as forcing detainees to stand for hours, are intended to make agony seem self-generated. You can read about this in the QBARC Counterintelligence Manual for Interrogation of Enemy Detainees, written by the CIA psychologists and doctors. Those who collapse later feel betrayed by their own bodies and minds. Shame and self-accusations haunt them. Particularly silent are those sexually assaulted, burdened by social stigma, shame, and the illusion of carrying a visible stain. Torture aims not only to annihilate individual lives, but also destroy collective, political, social, cultural, spiritual, and linguistic bonds, while seeking always to tarnish future generations. comprehensive treatment and care. If torture is the unmaking of a world, rehabilitation needs to be the making of a world. That is Unbroken's mission. Since 2022, psychiatrists, psychologists, psychoanalysts, medical doctors, body and art therapists have collaborated across disciplines and cultures, civilian and military, to integrate medical, psychotherapeutic, body-oriented, and social, legal, state-of-the-art care. Trauma's phases, acute, peri-traumatic, and post-traumatic, require differential approaches. PTSD symptom relief comes first. Long-term, psychoanalytically informed care follows, addressing the deep psychic wounds of extreme trauma. Treatment objectives. Responding to the dehumanization and terror and restoring trust are essential. At intake, a warm, attentive listener must quickly assess the patient's needs. The ultimate aim is to integrate traumatic memories so they lose their intrusive character and become integral part of the patient's life history. This requires negotiating subjective conflictuality as much as rebuilding agency, identity, self and body image, trust, reconnecting with one's family, and planning for a professional and personal future, which may include testifying as a witness in a war crimes tribunal. Challenges for the treatment team. Therapeutic work with survivors whose scars embody the violation of a nation's sacred values and most deeply held beliefs poses immense professional challenges. Specific training and experience in multiple treatment approaches, including psychoanalysis, is necessary for treating survivors of extreme violence. The dialectical tension between what can and what cannot be known of the torture experience and its short-term and lasting impact on survivors must be reckoned with by all caregivers. A psychoanalyst experienced with survivors of the Shoah called such trauma radioactive. It can possibly contaminate clinicians and must be addressed through supervision and staff care. In Ukraine's overburdened, high-risk context, protection from vicarious trauma is vital. Radioactivity is invisible and contagious. There is no vaccine against secondary traumatization. Only vigilant containment of its impact can preserve high-level care. Thank you.
Hello, dear colleagues. I would listen to those people forever. But it's a time not only listen and learn, it's a time to do something and to spread the knowledge. First of all, I would like to thank you for coming and doing this in Ukraine and today. And of course, it would not be happened without the leadership of Marta Kuzma, the professor of art, the leadership of ILAN, and the leadership of Andriy Zinchuk. Unfortunately, he's not here today. And for us, very important. It's also would not be happened without our colleagues. It's also not here. It's a YALE Foundation, originated from the USA. This is the Aspen Medical Global Agency, and Terry Rauch, thank you, Junior, and come to us today. It will not happen with another foundation, Semper Fi, and Americans Fund, that's helping us with the neuro feedback, very, very important technique. So thank you very much for all, because we are doing this for the world through the experience of Ukrainian people, unfortunately, during this war. Yesterday, we were talking that psychiatry made a few steps forward toward people. Psychiatry and psychotherapy have become closer, which means they are not so frightening and scary. It can be helpful. It's very needed. Why it's so important? The war has brought many challenges. But in our field, there are three huge challenges, and I call them the challenges of quantity. Before I tell you about them, I would like to recall one story that happened to me at the beginning of the war, not very beginning, like 9 months after the war started, the full-scale invasion. And the door in my office is open, and a young lady, like 23-year-old, with a child, a 1.5-year-old up to 2-year-old, come to me and said, "Listen, doctor, would you please give me my husband back? This is not the husband I sent to the front line." And she started to cry. I have no idea. I had no idea what to say. The millions of thoughts going through my head, and I started to think, I must be a doctor and say this is impossible. And I said, you know, this is impossible. We cannot go back. But, in the bottom of my heart, I knew that I have to say something that would give some optimism to this young lady. And I said very theoretically, from my scaredness, you know, but he can be better than he used to be. If we would help him, not only you, but me, city, family. It was theoretical concept in my head. I just said it because I want her to be a little bit optimistic. But now I'm pretty sure that it could be, we can build a new style of living after the trauma. And we are doing this together with our colleagues and our patients together. This is very important to understand it. It's not anymore theory. This is a practice that we can scale it up in Ukraine and in the other world. So, the challenges. The first challenge, I call it the challenges, the quantity challenges. And the first, the very important challenge that we all know, this is the quantity of patients. And in psychiatry, psychotherapy and psychology, it's not hundreds, thousands, it's in millions. And this is the prediction of, unfortunately, he was very close of the Minister of Health, Mr. Leshko, at the beginning of the war. It's going to be around 7 million people who would suffer from and 3-4 million people who would need a medical attention because of the psychological trauma. It was 2022. And 2024, WHO agencies also start to measure it and predict it. And they said there's approximately 15 million people would need attention, and 4,000 people or 4.5 million people would need the medical attention. This is the enormous numbers. That's impossible. We failed already. But we have to take it easy, and we have to go and what to do. But another challenge is also quantity, but low quantity. We have a problem with the providers. Yes, we can say in Ukraine we have hundreds, thousands of psychologists. Yes, we have. They have education and diploma, but they don't have a training in the trauma-oriented therapy. And not only psychologists, psychotherapists and psychiatrists. And this low quantity is a big challenge. Why it's happening? Because we are not learning and teaching why? Because it's invisible trauma. We don't see it. And that's why we are kind of, and also this is, as yesterday I said it, it's a phylogenetic, I think, fear of madness and the stigma of psychiatry. That's why we have to overcome it. We need more training programs for practical training in the field of psychological trauma. And that's why we established recently in our Unbroken system, Unbroken University. It's a postgraduate institution with teaching and science goals. And we are all welcome to in the field of mental health especially. And by doing, together with all these men, gentlemen and ladies, we are by fact establish a school of diagnostic, treatment, and research the mental health trauma in Ukraine. Let's just make it more and do it more structurally. And a few days ago, I visited a very good institution in this Boston. It's a home-based excellence center, and this is my next dream. Because we are very close in our activities, and thank you for coming and being with us today. But it's a good example to follow what we should do in Ukraine. And those excellent centers not supposed to be in Lviv, only in Kyiv and Odessa. It must be almost in every city of Ukraine because of the quantity. Remember this challenge, the quantity of patients is going to be worse. The war but this is a third challenge. The war has become a significant challenge for medical professionals working under the extremely stressful situation and conditions, facing physical, emotional, and psychological burnouts. Vicarious trauma. I would like to tell very short. Unfortunately, I am the one who felt it already half a year ago. I start to have nightmares. I start to have a different attention and I start to worry about myself. So I'm learning, I'm teaching, and I'm survival? Yes. And I went to the EMDR therapy, and I'm fine, I'm staying. I have to change my style of living, that's true. I have to work with my guilt that I am not having 12 person per day patients, and now I have 4, because I have to take about myself, and I have to take because I can be taken care about others. And we have to teach it, people, because otherwise we're gonna have a big problem. I would like to end my presentation I will not, about the story. A very usual patient in our hospital, a young soldier, 27 years old, suffered from multiple traumatic brain injury. The mild one, concussion, so-called concussion, invisible, during the defense of Mariupol, where he was close to death after seeing the eyes of death and suffered a psychic injury that manifests in the severe PTSD. He was captured and spent 1,111 days in captivity, where in addition to physical and mental torture, he endured moral trauma to body and his dignity. Unfortunately, there will be tens of thousands of such boys and girls. They need what they need. They need respect from us. They need care, 100 exclamation mark, care from us, and need a professional knowledge that we start to gain now. Therefore, we must increase the availability of psychiatric and psychotherapeutic services, and say tomorrow, open departments in multidisciplinary hospitals, establish outpatient mental health care centers in primary health care level, involve the quality of services and ensure the multidisciplinary approach in diagnostic and treatment, train in diagnostic people in of PTSD, trauma-related condition, TMS, neurofeedback, and other things. So we must treat at the same moment, learn, teach, and research. And this is the key to our survival and victory. We must do it together with you, United, Razum, Nova, Aspen, Unbroken, and universities in Ukraine, hospitals in Ukraine, universities in Canada, United States, European Union, and other. Thank you for listening, for being with us together, because only together we can survive and win.